Milé dámy, vážení pánové, pěkné odpoledne z virtuálního studia České kardiologické společnosti. Rád bych poděkoval firmě Philips Česká republika za to, že máme dnes možnost seznámit se v rámci tohoto sympózia s nejnovějšími technologiemi v oblasti zobrazovacích metod za použití magnetické rezonance a CT. Dovolte mi, abych tady přivítal kolegy z Philipsu, který předávám úvodní slovo a poprosím je o shrnutí toho, co diváci dneska mají možnost poprvé vidět a poznat.
Dobrý den, já jsem velmi rád, že se firma Philips může účastnit tohoto významného kongresu a že vám takto můžeme představit novinky v oblasti zobrazovacích systémů, které se nyní používají v kardiologii. Mrzí mě však stále, že situace nám nedovoluje setkat se osobně a že nemáme možnost prodiskutovat všechny tyto technologie i v kuloárech. V letošním roce jsme si pro toto sympózium připravili trochu netradiční formu prezentace. Za malou chvíli se propojíme s naším Customer Experience centrem v Holandsku, kde si pro vás naši kolegové připravili sérii klinických ukázek. První část přenosu se bude věnovat magnetické rezonanci. Představíme vám koncept Smart Workflow, který usnadňuje práci laborantů a významně zvyšuje komfort pacienta při vyšetření. Při vlastním skenování poté budou použity nejmodernější akcelerační techniky Compress Sense, které umožňují v porovnání se standardními protokoly získat za stejný čas více řezů, zlepšit rozlišení, a to jak prostorové, tak i temporární, zlepšit detekci toků a například i zkrátit nutnost zadržení dechu, což bývá často při vyšetřeních kritické. Všimněte si také, že veškeré rekonstrukce probíhají okamžitě a bez nějakého znatelného zdržení. Druhá část přenosu se poté bude věnovat spektrálnímu CT a jeho využití v kardiologii. Budeme mít tu čest představit vám nový tomograf CT 7500, který měl včera světovou premiéru. Na klinických příkladech uvidíte široké využití spektrální technologie v kardiologii, která je díky unikátní konstrukci detektoru neustále k dispozici. Každý zachycený foton se počítá a přispívá tak ke stanovení správné diagnózy. Věřím, že se vám ukázky budou líbit a předávám tímto slovo kolegovi Karolu Mikuláši, který krátce představí platformu používanou v našich ukázkách pro postprocessing.
Dobrý den, taky děkuji za pozvání. Z mé strany bych chtěl tady dodat, že k novým metodám zobrazování srdce patří i postprocessing získaných dat. Část následující sekce, především v oblasti CT, bude demonstrováno online s využitím platformy Philips pro pokročilou analýzou obrazových dat pomocí IntelliSpace portálu. V nejnovější verzi IntelliSpace portálu se lze těšit i na umělou inteligenci v oblasti postprocessingu srdce, jeho segmentaci, také dále nové aplikace myokardiálního strain a 4D flow postprocessing s možností měření dynamických a tokových parametrů. Nyní prosíme o přepojení do Customer Experience centra v Holandsku. Děkuji.
Thank you very much for the introduction. I also would like to welcome you. My name is Ulrike Blume and I'm the Clinical Portfolio Manager for Cardiovascular MR here at Philips. You might be wondering, why is Philips now highlighting its MR solutions here today? And the reason behind that is that we are noticing a very strong increase in demand for cardiac MR examination due to, on the one hand, a further increase in the guidelines, like for NOCA patients, where MR is now a class 1 recommendation, but also due to COVID-19, where more and more studies are showing a severe impact on the heart, so myocarditis is being diagnosed in these patients very often. Now, this increase in demand, of course, creates a tension between the cost of care on the one hand and the diagnostic confidence on the other. And therefore, we at Philips, we are trying to innovate around these two major needs, to reduce the cost of care, but also to increase diagnostic confidence, because we want to make cardiac MR more accessible. There are, of course, many products in our portfolio that are having an impact on these two major needs, and we will highlight and demonstrate a few of them here today. So, for example, Smart Workflow, which provides you with guidance and automation where you need it, or Compressed Sense, which helps to increase patient compliance by reducing breath holds, as well as our latest innovation for our image post-processing platform, IntelliSpace Portal. Yeah, and with that, I would like to hand over to my colleague Karthik for the system demonstration.
Thank you, Ulrika, for the introduction. Welcome to the live scanning portion of this presentation. Before we switch to the live scanning, I would like to show some features at the magnet room designed to enhance the workflow and allows the technologist to focus more on the patients. I will emphasize on the vital screen and vital eye that complements the cardiac scanning workflow. And here you see the vital screen, which is available on both the sides of the magnet. And the vital screen provides guidance and insights on the current study. So when I touch this icon, you can already see the information about the patient and also the weight of the patient and also what type of study it is, and if the study has a breath-hold sequences in it, and if the contrast agent is required or not. It also provides guidance on how do you position the coil and also the accessories required for the coil positioning. And most importantly, for cardiac MR, it also displays the guidance on how do you position the VCG electrodes, and once the VCG electrodes are positioned, it provides a real-time feedback on where you can see the VCG waveform already on the vital screen. So you now already know what is the heart rate of the patient whom you are going to scan. And in addition, the vital screen also displays the respiratory graph, which is being picked up by the vital eye technology. And this vital eye provides a touchless patient sensing without any operator intervention. Now we have the patient positioned, and we'll move on to the scanning part, to the console room. And with the vital screen, I can also already start the scan from the inside, and when I close the magnet room, the scan will already start. Thank you.
Thanks Karthik. So I'll start the scan. In the meantime, let me give you some information about compressed sense. One of the biggest challenges in cardiac imaging is the image quality. Therefore, you will need the collaboration of the patient, for example, breath hold, no motion. So most of the exams are done in breath hold. And the challenge is to have the shortest breath hold time possible. We within Philips managed to reduce the breath hold time for most of the sequences with the use of compressed sense while maintaining good image quality. In this live scan session, we will demonstrate the comparison between the conventional sequences and compressed sense sequences. The advantages of using compressed sense are that you are able to keep breath hold times as short as possible, maintain the high image quality, and reduce examination time so you can scan more patients in a day. Now I'll show you comparisons of multi-slides short axis seeding, black blood, and a Q-flow with and without compressed sense. Let me switch to the review. So here you see a comparison of sense sequence, series sequence, short axis, and a compressed sense one. The scan time of the sense one was 12 seconds, and with compressed sense we went down to 9 seconds. It is a multi-slice, so I can just stop the movie a little bit and then scroll through the slices, and then I can just compare them again. I did another scan to show you also that you can go faster with compressed sense, like going through the whole heart, only in 1 or 2 breath holds. This is a 2 breath hold scan covering the whole heart. Each breath hold was done in 10 seconds. So it's a multi-slice covering the whole heart. Going to the black blood examples, here you see an example of the black blood. In short axis again, the left image is in 16 seconds, meanwhile the right image with compressed sense is in 10 seconds. And last but not least, I also scanned an example of a flow to show you that compressed sense can be used not in different orientations or different weightings, but also in flow, keeping also the same flow results. So at the left again you see the sense sequence, meanwhile at the right I will show you also the complex sense sequence. I will put it in the movie. There we go. So you see nicely ascending, descending aorta, also the outflow tract, one with compressions, the other one without compressions. The time gain was from 15 seconds to 10 seconds. We just showed how to speed up protocols by scanning with compressed sense. Now I want to switch to show a quick preview on two analysis packages. One is the functional analysis package, and the other one is the 4D flow package. So the functional analysis is based on a simplified AI workflow and automatic results. We use here AI-based algorithm for automative, functional, and quantitative results. So the contour detection will be done automatically using this AI-based algorithm. You can program it in a way that when you load the case into the ISB portal, that the system will contour the detection automatically without any interference of the operator. The idea is that you can just easily load the case, and then your global results will be there automatically. So we say it is only with one click or non-click. So what you can see here, I already loaded it, the case, and it already gives me the results. If you go through the images, you see here that the contours were automatically detected and very nicely detected the EI and the endo contour. You see here at the right also the two other directions. So the only thing I have to do is go to the results. For the global results, I go to the next step, and then you see directly here at the right side the numerical results, so ejection fraction, stroke volume, cardiac output, and you see also here the flow chart here at the top left, and at the bottom left you see here one of the slices, and at the right one quantitative result. So in this case is the wall thickening, relative wall thickening. If I want to see the detailed results of the left ventricle, I can just click over here, and then I'll see directly also the wall thickness, the wall motion, the wall thickening, and the time of maximum thickness. This permits the operator to do an analysis in less than 5 minutes. So this was a quick preview of the left ventricle functional and quantitative analysis. The next package I want to show you is the 4D flow analysis package. As you can see, I've already loaded the modulus image in the main viewport, and down here the 3 face images in the 3 viewports down here, from left to right, feet, head, and AP. This package has task guidance, so by following these steps, it should be easy to do a complete analysis of the 4D flow. So if I go to the next step, I'm going to the viewing environment. So here I can just view the image in the 3 directions. I can turn it and scroll to it. Going to the next step, it will ask me to put the 2 points to follow the aorta, for example. So I'll put the first one here at the base of the aorta, and then the second one is in the aorta descending. So as you see here, those 2 points. Here down here you see already the full flow chart. By going to the next step, it will directly show me the streamlines, so from the aorta, as you can see here. I can also show the path lines, so see how the flow is going during the heartbeat, the heart cycle. As you can see here, Each cycle you see how the flow goes. And also there's a possibility to, for example, show the vector fields. So by changing the slides, you see also how the flow vectors goes down. Down here, it will show you the flow chart and also here the results. So for example, the cardiac output and the volume.
Now we have come to the end of this demo, and we showed you how the vital screen and vital live helps to improve the workflow, and then we showed during the live scanning how compress sense helps to speed up the examination, increasing the productivity, and at the same time improves the patient comfort by decreasing the breath out duration. And after that, we also showed using the ISP workstation version 12, where the cardiac analysis package is powered with AI with automatic segmentation, helps the radiologist, and also we showed you a sneak preview of the new 4D Flow application package. If you'd like to know more about our cardiac solution, please visit the cardiology webpage of Philips. Thank you.
Thank you.
Dámy a pánové, děkuji moc, že jsme mohli tedy vidět tu první část týkající se magnetické rezonance a především ten postprocessing, který byl zcela inovativní, jak kolegové tedy říkají, bude teprve postupně zaváděn a má ve své gesci celou řadu kardiologických aplikací, což je pro nás nesmírně důležité. A dovolte mi, abychom se dostali ke druhé části a tou je vlastně premiéra zcela nového CT systému, jak kolegové říkali, světová premiéra včera a dnes je to v Praze, respektive v České republice, tak to je velice potěšitelné. Good afternoon. Could you hear us? Can you hear us, please?
Yes, I can hear you.
Thank you
Good
for
afternoon.
being with us for the annual Congress of Czech Society of Cardiology. We're very happy that we can have the presentation about the brand new CT system. Please start your presentation, and then at the end we'll have questions, and you will be so kind and answer our questions. Yeah, thank you very much.
Okay. Well, first of all, thank you for the invite. Feel proud to present. Good afternoon. My name is Rolf Rijmakers. I work for CT Clinical Science, and for the next 30 minutes or so, I would like to take you on a journey on spectral detector CT and how it will improve diagnostic confidence within the cardiovascular domain. Well, it took a while, almost 20 years, but now for sure, the door to non-invasive coronary CT is wide open. I remember myself, I started doing cardiac CT in 1999, and it took 40 seconds. So it took a revolution. But now, being able in a robust fashion to perform, for example, 50 cardiacs in a 16-hour time shift is pretty impressive. Independent of the heart rate, it's very robust and it will show diagnostic results. So that is great to have. Of course, when you then provide image quality as such, as shown over here, as one can see over here. So this is a filter back projection, which is an old-fashioned reconstruction. This is a hybrid iterative reconstruction. Over here, we see our iterative model-based reconstruction. And it doesn't take much to identify a lesion, which is here in the prox LAD, right? But if you look at this image, you know, this is a completely noise-free image. And especially when you go to the lower right bottom part, you see a cross-sectional image, let's call it an IVUS cut, and then it's really, really impressive how well one can define the outward remodeling and the extent of the non-calcified plaque and the borders between the non-calcified plaque and the pericoronary fat. And these maps, if you provide in a robust fashion 50 patients a day with image quality like that, which allows you to assess high-risk plaque features like napkin ring sign, spotty calcification, and then one could only wait for publications like this. And this is one of the landmark papers which resulted in the NICE guidelines. And the NICE guidelines in the UK recommend cardiac CT as the first-line test for the evaluation of stable coronary artery disease in chest pain pathways. So there again, that's the underpinning. The door to cardiac CT is wide open. Now, when you start doing cardiac CT, and some of you might have already tasted the flavor of it, there are still many challenges. Now, and if we set aside the acquisition challenges and do not focus on native temporal resolution only, there are still many challenges that if we freeze the coronary arteries, we're happy, but we are still facing issues like blooming of high density objects in calcified plaques and stent. We suffer from beam hardening artifacts, and it's especially hindering in plaque assessment and or myocardial perfusion. We often are confronted with patients who suffer from a poor kidney function with GFRs below 30, and then the iodine injection is becoming an issue. We see that especially in TAVI patients who do not accept a lot of additional volume and or iodine. Not all the times we have a successful CTA. Sometimes the PDA is not very well specified, and then we know if cardiologists like you don't see a very well specified PDA, your guy's getting nervous. We are confronted with plaques, and we see non-calcified plaques, and we think those are very, very important risk factors. But it's very challenging to identify, am I looking at a fatty or a fibrous plaque? We're dealing with issues in the left atrial appendage. When you're running a CTA, a cardiac CTA, sometimes you see there is something going on in the appendage, and then you don't know whether this is clot or is it a slow flow thing. And that might you might decide to send the patient to another modality, to ultrasound, for example, to reach diagnostic confidence there. And in the area of viability, which is MR territory, I know, but there are still issues there, especially in the delayed enhancement scans. Now, all these obstacles, all these challenges we see on top of freezing coronary motion, you can all link them to conventional CT, to the single energy nature of conventional CT. Now, these issues, you do not solve them by going to a very wide cone, a very wide detector like 16 centimeters. You do not solve them by spinning around ultra fast like a flash mode. Those things which I addressed here, they are linked to the single energy nature of conventional. You can only address them by doing something different. And what is the solution? The solution is called spectral detector CT. Now, every photon counts. So instead of looking at only conventional CT images, which are used to look at, which are coming from a single energy acquisition, we maximize the value of each and every photon by providing novel maps to you. And these novel maps are coming from two energy levels. And these maps will enhance your diagnostic confidence level without a single penalty, which is a crucial thing to remember. On our platform, we're running a spectral CT without a penalty in temporal resolution, without a penalty in radiation dose. We do not exclude the obese patients. We don't suffer from resolution and more. How do we do that? Well, I already told you, we need to have two energies. Now, there are different ways of doing it. Philips is doing it in a unique way. We've changed the detector. As you can see here on the right, this is our detector module. And on top of the conventional detector layer that everybody is using, we've added an additional layer of yttrium. And yttrium is very sensitive to accept the low energy photons which leave the body. The higher energy photons leaving the body will be absorbed in the lower layer. So at the detector level, we end up with a low energy data set and a high energy data set. When we load these two data sets in the reconstructor, we can calculate a photo scatter map, and from there we can extract all spectral maps, which I will elaborate on now. So this is spectral CT based on a dual layer detector. Other vendors are trying the same, but they don't have this detector-based approach. They are doing dual energy CT based on the source. So they're either emitting with two energies, with 8140 kVp, or they do something else. Philips' approach is unique, spectral detector CT. Now, spectral detector CT in Philips comes in two flavors. First is the Icon. That product is released in 2017. It has a 4 centimeter coverage, and for the obvious reason, it was there more for a general radiology focus. However, we did a lot of cardiac scanning on that scanner already, and now released yesterday. We're very proud to talk about the spectral CT 7500, which has a much more dedicated cardiovascular focus, and for that reason it has an 8 cm Z coverage. So spectral CT 7500, it's an end-to-end solution for your routine and growing cardiology needs. So it comes with multiple features like a 0.27 second rotation time, which is not hindered when doing spectral assessment. We are running with an 8 cm detector. We have a wider bore, 80 centimeters, so it allows for the obese patients. We have a very powerful tube, the 120 kilowatt. We have a new fast table, which is also allows the obese patient, but is capable of scanning really, really fast on 60 centimeters per second. And very new and unique, we are allowing you to do spectral CT with the 100 kVp station, and then the radiation dose is really, really competitive, if not better compared to other vendors. So it also comes with an AI-enabled algorithm called Precise Cardiac. It allows us to extend, let's say, the heart rate range to do step and shoot, axial prospective imaging of the coronary arteries. And as you can see here on the left, if you go to higher heart rates, in this case 77, the temporal resolution of the scanner might be not sufficient to freeze, or there might be something going on there. Right, and if you see here in the stretched curved MPR, there is blur. So this is definitely coronary motion. Now there's no need to despair, because with this AI Precise Cardiac algorithm, we can salvage that image. And from a non-diagnostic segment 1/2, we made it into a diagnostic segment 1 and 2 with an AI-based Precise Cardiac algorithm. You can see it also here in the axial plane, typical phenomenon of a blur due to cardiac motion, but then when you apply the algorithm in a retrospective fashion, you end up with images like that. Now, what do we bring to the table? Well, in order to make every photon count, we provide you with a lot of additional maps. It's like in MR. In MR, you have different sequences to query different diseases. Now, in CT, with spectral, we provide you with conventional, of course, with virtual mono-E, with iodine images, with virtual non-contrast images, and so on. So you have a lot of maps to choose from. It doesn't mean that you have to use all these maps in every single patient. No, each map shows value in a specific query. So before jumping to the workstation, I would like to go through a couple of examples in a slide format. In this case, how would you use it? So this is a patient, it's a follow-up study after an elephant trunk procedure. And then, you know, this was in the patient came to the hospital with atypical chest pain. And knowing this procedure, so they did a CTA, and then, well, this is the the aorta. That's the kind of the bypass that they did. But here, there is a density which is similar to the iodine concentration in the lumen. So what is this? Is this extravasation? Is this endo leak? Or what's going on? And that's a serious condition, right? And you need to make a proper, confident diagnosis. Well, with conventional CT only, single energy, one cannot solve this problem. And you need to send the patient to another modality to make sure that to get a right diagnosis. You might even send the patient for no reason to a cath lab. Well, if you apply spectral, what happens on our platform? You just push one button, and then on your PAC system, you can access spectral data at your fingertips. And then here, if we narrow down on this section with spectral magic glass or a spectral stethoscope, we see 4 different maps. Now we go one by one. So I'm interested in this, and I want to know what's that? Is that iodine or is that something else? Well, if I look at my iodine image, iodine or water, all the structures which contain iodine are highlighted here. So this is iodine, but I don't see anything there. Oh, so this on conventional looks like iodine, but on my iodine image, it doesn't show any concentration of iodine, which is cool. Let's have a look at the virtual non-contrast. The virtual non-contrast here to the left is an image where the iodine is extracted from the image. And as you can see here, this metal clip is there, and this also is visible there. So what's this? Now, with 100% confidence level, you can say this is a surgical felt used during the procedure. So this is not an acute endo leak or extravasation. No, this is pre-existing surgical material. So from a diagnostic dilemma, you bring the physicians to a diagnostic certainty. And that's what spectral is bringing to the table. Another case, as I told you, one of the obstacles is that we are dealing with patients with sometimes with poor renal function. Now the scanner now, spectral detector CT, allows you to do coronary CTA with only 18 mLs per second. You have to see the images, otherwise you won't believe it. And we're all trained, if we do CTA, we need to inject high flow rates like 4, 5 or 6 mLs per second. Well, no longer. If we apply virtual mono E, when we use 2 mLs per second, 18 mLs in total is satisfactory. And then if we look at virtual mono E, 40 kilo electron volt, for example, we get a maximum iodine boosting. Now, if you look at this image, you would definitely say, well, this scan was probably acquired with 5 cc's per second with 400 milligram per milliliter. No, not at all. 18 mLs at 2 cc per second, but we just make use of the high quality results of low mono E. So in this way, we address patients with poor kidney function. And here, as I also mentioned before, TAVI patients, they don't tolerate a lot of additional volume. They don't tolerate iodine neither. So what's the solution? Spectral detector CT. And then we have a complete gated assessment of the entire aorta, inclusive subclavian arteries and femoral arteries for access route assessment. And we are able to do that with 35 at 2 mLs per second. And we can push the boundaries even more. But in this image on the left, on conventional CT, it looks like an aquarelle, a water paint, right? But you can change the aquarelle into an oil paint by simply moving a slider, which I'm going to show you live in a second. You go to 40 kilo electron volt for boosting iodine, and now you have a highly diagnostic CT angiogram pre-TAVI with only 35 cc's. Now that's making a significant difference to your patient population. Patient came in with atypical chest pain, and then, okay, this is conventional CT. It's already exquisite image quality, but you know, we always suffer from blooming artifacts, right? And calcium and high density structures always appear larger than in reality. And that's the Achilles heel of CT. So what can we do? Well, instead of looking at conventional, we're looking at another map. Why don't we look at an iodine map? And in iodine maps, you see we are providing you images with a significant reduction in blooming of the calcified plaques, which allows for a more accurate luminal stenosis assessment. What about this? This is already challenging to do, right? Recurrent chest pain after stent placement. Well, this patient had many stents within the RCA. And then, okay, the diameter is okay in the RCA, 3-4 millimeters. So it's okay to do according to the guidelines. And then you end up with images like that. And then what's going on there? I see there's a dark area, but you're not sure. Is there now instant restenosis, yes or no? And if you don't know, you're going to send the patient to the cath lab, right? Because, yeah, it might be a serious condition. Well, if you have access to spectral data and you change the conventional CT, where there is a diagnostic dilemma, into an iodine or water, now everybody in this online symposium will know definitely this is a subtotal instant restenosis. And look at the distal stent there. There might be some doubt in conventional. Here in the iodine or water, there is just no doubt at all. So there is a significant instant restenosis in RCA. For this reason, the patient legitimately was sent to the cath lab, and there you go. There is an excellent correlation with the invasive cath. Perfusion, if you look at myocardium, this patient came in with NSTEMI, which is a borderline indication, or not yet, but it's part of research. And then we did identify a lesion in the POX LAD, and then you scroll and nothing else really stood out. And then you look at the myocardium, but you don't see any differences in densities there, right? Unless you're going to look at low mono E. And again, low mono E, in this case, here we see, well, the perfusion is homogeneous over the entire LV myocardium. But if you look at low mono E, see, this is really obvious that there is a hypoperfusion. So this is first pass perfusion deficit showing you here in the septum anterior wall. And see, especially when you compare this section to that section. I will show the case later on the workstation and show you how you can quantify. So these were a few examples on what spectral CT can do. And yes, all your challenges in cardiac CT which I mentioned in my first slide, they are resolved, and if not resolved, they are for sure mitigated. And that's what's bringing spectral, that's why spectral detector CT brings in a lot of value in the cardiac domain. With that, I like to end this session, checking my time, and I'm okay on time, and I would like to swap to a workstation and go through a couple of cases in a live fashion so you can see how this workstation works. So again, I'm going to share my screen. I'm going to go to my workstation there. Well, it went to sleep. In the meantime, won't take long. So many people think that having to deal with multiple energy data sets is cumbersome and time consuming. And I just want to show you that it's not. I hope the slides were already pretty convincing, but yeah, in a slide, you can do everything right. So why not show it live? The first case that I would like you to show is, and I opened up my presentation with how robust the technology is. So this is a patient with atrial fibrillation, and the heart rate went everywhere, which is not a very, very good condition to get robust cardiac imaging, right? We always target heart rates below 65 in a stable rhythm, but we don't always get them like that. Now, if I show my ECG graph like that, you can quickly see the mean heart rate during scan was 96, and we saw a standard deviation of 23. So there were a lot of arrhythmias present during the scan. Well, I just want to show you that this 8 centimeter 0.27 second platform is capable, although this is coming from an icon scanner. So this was 4 centimeter, but it has, despite the 4 centimeter coverage, it had excellent temporal resolution and excellent built-in algorithms to deal with arrhythmia. So this is exquisite image quality. If we look at the conventional CT, it kind of looks like that. And what can you do? Well, the existing evaluation packages, which were only meant for conventional CT, well, we easily extended them and added spectral to it. So I can easily jump here to virtual mono E, and I can play with my energy levels, right? I can go to high mono E, or I can go to low mono E. Low mono E is boosting, excuse me, is boosting iodine. So you will always have the very well opacified distal parts of your vessel tree. Sometimes it's arguable, am I looking at a plaque rupture or is this pre-existing calcification? If you don't know, well, you just change the image into a virtual non-contrast. There you go. And one can quickly see that the calcium remains here on the aortic leaflets, but the iodine is extracted from the images, and this could help you whenever there is a challenging plaque to read. So that's what it's doing. It's doing robust cardiac imaging without the penalty in temporal resolution. We provide you with spectral maps, which can help you to be more confident in many cases. Another example is yes, let's jump to this one. This is a patient with a, again, with a stent in the prox to mid LAD. So stent size wise, it was an okay indication to investigate with CT. But again, then there is a challenge, and I showed this case to many of your peers, whether they were cardiologists or radiologists or cardiac imagists. And I all asked them, okay, what do you think? What's going on in the stent here? So there is a, it's prox mid LAD. And everybody said, well, there's nothing going on. That stent is patent, nothing going on. This is not the reason for recurrent chest pain. Well, are you sure? Well, you can zoom in and try a window and then, yeah, there might be something in the proximal part. Might be. We don't want to have the words of might be in the reports. We want to have diagnostic certainty. So how can we provide that? But of course, this could be beam hardening artifact, right? Well, let's jump. Let's jump to an iodine or water map, which I showed you in a slide format. See, in a very rapid fashion. It's very easy to do. You just change your conventional with one click into an iodine or water. And now everybody again here, present in the online webinar, you will see with diagnostic confidence that there is an instant raised stenose. We can apply our spectral stethoscope if we want to further interrogate the lesion. I'm just gonna zoom I'm going to plot my box there. And in this case, for example, I'm going to use my Z-effective map, which is looking at atomic numbers, and it clearly identifies the different tissues, right? This is the iodine within the vessel, and it's color coded. So when it's a high atomic number, it's more towards blue. So when there is a lot of iodine or metal, it's blue, but this is almost the color of fat in Z-effective. So this has very, very low densities. So again, all these maps help you with great confidence. Initially, you would say there is nothing going on, the stent is patent, or that I don't know, it might be beam hardening. Now you have your diagnostic certainty. Without a single penalty, I cannot stress that enough. It's on in every single patient. There is no choice a priori. You don't have to tell the radiographers, please scan this patient in dual energy. No, on our system, every scan is a spectral scan. Now let's have a look at this one. Quickly checking my stopwatch. I'm still okay time-wise. This is that patient. This is that patient from with an N-STEMI. Did I load this? I'm going to load it now. I'm going to show you the lesion in the LAD. This was a case from New Zealand, and the cardiologist on site said, Rolf, I have a patient. They just had the scanner. And again, this is from a 4 centimeter configuration. So only think what will happen if you now start to work with a spectral CT 7500, which is an 8 centimeter configuration. Everything becomes even more easy to do, especially in cardiac. Well, this was a scan, and you see we might see the culprit lesion there in the prox mid LAD. And again, if you you don't see a lot. Again, if I'm here in my workstation and I have these user-definable presets, I can quickly identify areas of hypoperfusion, right? Hypo-intense areas. And if I go to the right lower image, one can see again the effective atomic number images, and again it becomes even more apparent that this section there is definitely less iodine compared to the free wall. Can we quantify? Yes, of course. So what I'm showing you here, this is an iodine image on top. It's fused on top of the conventional CT. So conventional, you don't see a lot, right? But when you add your iodine information, it becomes really, really apparent. And now the cool thing is there because we can quantify. If I drop an ROI in the septum there, I can measure 1.35 milligram per milliliter. So there is still iodine penetrating, but way less compared to the free wall, right? This is 2.7. Now the research now is focusing on if we normalize to aorta, would this value of 1.35 could we establish a kind of a threshold above which we don't need to send the patient to cath and below which we do need to send the patient to a cath. Whatever. That's key research as we speak now. I need to have time. I need to leave time as well. I have 2 more cases to show. Oh no, this one. If you have patients with atypical chest pain and they have slightly elevated troponin levels, and you're gonna do CTA of the coronaries, and the coronaries are normal, yeah, most likely it could be myocarditis, right? And then MR is the gold standard. But again, with CT, things become very, very easy. What you need to do is you just have to wait 8 minutes after your CTA, and you might have to add a little bit more iodine as a second injection, wait 8 minutes, and then you assess. And here in short axis fashion, you can see this typical subepicardial late iodine enhancement. It's much better visible when you start using low mono E, 40 keV, as I showed you in the vascular studies. It's boosting iodine. And then over there in your fusion images, see how beautiful. Now, this is the typical signature of myocarditis. So why not? I know MR, I'm not fighting MR. MR is the gold standard here, but there are always patients who show contraindications. And if the patient is on your CT with slightly elevated troponin levels, you don't see coronary lesions, why not wait 8 minutes and do the second scan here? This is very close to the one-stop shop, right? In high accuracy, one can establish, it allows you to establish potential late iodine enhancement. All with spectral detector CT. Now, the last case, which is, I think, really an exciting field, which is gonna start again. This is sarcoid, And sarcoid, again, this is a structural heart disease. So we are really in the MR territory, but there are quite a number of patients, they show contraindications, right? To the MR, claustrophobia, or they have implants or whatsoever. So again, what do we do? And this is a study coming from Japan where they are trying to see and prove non-inferiority of CT versus MR in this kind of patient. So this is again a delayed enhancement scan. We see the scar and delayed iodine enhancement here in the basal part, and over there. Beautiful. If you look at your iodine, at your low mono E, it becomes even more apparent. We have our iodine density image, and iodine density images are beautiful because they allow you to quantify extracellular volume. Now, how do we do that? I just need to load this data set into a newly introduced software package, which is multi-phase analysis. So you give a certain amount of iodine, you wait 7 minutes, and then you load your spectral data set in this multi-phase analysis package. We're going to go for non-Hounsfield units based, and I want to extract extracellular volume. No, it's not difficult at all, right? There you go. This is the same data set. We see it over there. Non-Hounsfield unit, extracellular volume. I'm going to approve. And now I need to calibrate to the aorta. So I'm going to create an ROI, and I put the descending aorta, normalize. And you see with 3-4 clicks, approve normalization, sorry. And now you get this color-coded overlay, which shows you the percentage of extracellular volume. So yes, one can quantify by dropping an ROI, and then you can see here extracellular volume, which helps you to assess myocardial fibrosis, which is a sign for myocardial damage, right? Although MR territory, I would like to stress that there are patients with contraindications. So please think about CT, and please think about this spectral detector CT and all the value that it shows in cardiovascular imaging. Now with that, I like to I reached the end of my presentation.
It was a great presentation. So the spectral detector CT seems to be very promising technology, especially for cardiology, because we wait 10-20 years for tools like this. There are some questions from the audience. Can we start with the discussion, please?
Yes.
Yeah, talking about perfusion. If you are comparing the standard like MR late gadolinium enhancement against the imaging you showed in your presentation, it's comparable, or is still ML gadolinium late enhancement a gold standard for the future? So what about this?
Well, yes, it's gold standard, right? And again, we're not trying to fight or taking or stealing patients from MR. This works pretty well, although it might be challenging still on MR, as we hear. One of your colleagues, Professor Gerbert from UCL in Brussels, he published several papers on late iodine enhancement, comparing MR to delayed enhancement CT, and the values really correlated. So yes, one can do it. It's as accurate as MR. And it's, well, the areas are better defined, right? Because of the better spatial resolution.
Yeah, thank you very much. Next question is, we as a cardiologist, especially electrophysiologists, we need image integration. So what about the possibilities to have an image integration with this spectral detector CT system and CARTO, 3D mapping, IVOs, and other methods, intracardiac ultrasound and things like that, because this is essential for the quality and safety of the procedures.
Yeah, that's a very interesting question. Thank you. During my visits abroad, I ran into a professor of electrophysiology, and I showed him what we can do with late eye enhancement and better visualizing the scar and the extent of the scar in the left ventricle wall. And then in our software tools, Comprehensive Cardiac, for example, we are better able to segment that and export that as a tissue through biosense. And then you can project it in the cath lab. And then, for example, the EP physician is then better guided in attacking those lesions which cause all kinds of tachycardia or arrhythmias. So yes, that is a field to explore for sure.
Mm-hmm. This is very important. And what about the image integration with the echocardiography? You have an excellent ultrasound machine for cardiology. We are very frequent using intracardiac echocardiography eyes. What about this image integration? Because this is again essential.
Yeah, well, for this, I didn't have any, and I'm not a physician like you, and I'm not a physicist. So now you're really over asking me, but I will definitely take the question back to my team.
Yeah, thank you very much. Because the future lab, how it will look, is certainly set, let's say, 2 rooms in one line. First one is the CT, and the second one is the angiography. So we can immediately act based on the, let's say, results of the spectral detector CT and follow the procedures to the interventional cardiology for any other procedures, invasive procedure, what we need. So does Philips has this concept of this integrated labs, CT, like you showed, plus angiography in one package? Because this is the future for me, especially. Yeah.
It is the future, and I can't say more, but yes, we are definitely working on a solution as you are describing here.
Yeah, because it will be always, let's say, customer individualized solution, how they will need it and feel it. For another setting will be for the interventional cardiology, another one for electrophysiology, but yes, it seems logical to have everything in one house, in one space, to have a better treatment for our patients.
For sure, and the same holds true for the radiology, for liver ablations, etc., etc. So it's going to be a common.
You know, we are always a little bit fighting with the radiologists, because we as a cardiologist, we like to have our own CT, MR systems, and this is always true, not only in Europe, also in the US, but there is a more, let's say, pronounced the concept of special radiology-oriented cardiologists. They are doing this procedure, so we have to teach the young generation about this approach. Yeah. Colleagues, do you have any questions to the presentations?
Not from my side.
Yeah, and you?
I think everything was answered. Thank you.
Thank you very much once again. It was great, and we hope that we can use those novel technologies in our daily life and also in some centers of scientific research we are planning right now. So it will be very interesting. Have a nice day, and thank you very much once more for the excellent data. Thanks.
Thank you very much. Bye-bye.
Bye.
Thank you.